has been, was very instrumental even before when we were trying to get the attention of the leadership of its 9 healthcare systems, that this is not just about statin prescribing, this is not just about hypertension control. San Diego being one largely managed care, very good managed care penetration, it was a way to sort of get the healthcare systems to say, in the long run, we'll be able to lower the total cost of care, and that's why, hence, please support with your health coach, support with your pharmacist, and all those things. So that's, you can see the cost avoidance was $86 million. This was a very conservative estimate. If you look at the paper, it was based on a 30-day episode of $22,000 worth of episode cost. It was this cost avoidance was based on that. But we all know that cardiovascular disease is an ongoing illness. There's a domino effect, and there's a downstream cost too. So we run. UCSD has one of the largest Medicare ACOs. We have almost 32,000 lives in 3 counties. What I did was I just took a slice. The 10,300 members which are with UCSD. UC San Diego for Medicare ACO. And we looked at what was our healthcare expenditure around ischemic heart disease. Around 408 members we had to spend of almost $21 million. But when you look at it, the downstream, it was just not hospital. It's also inpatient cost, it's the SNF cost, it's the outpatient cost, it's the imaging cost. So the total cost is almost $51,000 per member per year on the ischemic heart disease. So if you can do just a little bit of math with me, if you take the top line, $21 million, and we could even just lower it by 5%, that's almost $1 million of cost avoidance or saving. Compare that to the merit-based incentive program where we could do all the work and we got $300,000 only. Where we could, we could use the $1 million to go to our CEOs and finance people and say, these dollars will help us to build the team necessary to drive in the fundamental change inside us. So what I'm requesting you is to help me to help you, I think how can you help us to really drive that change, and by trying to lower some of the hospital inpatient costs. So the next decade, 2020, we had a wonderful summit 2017 at Berkeley. We all celebrated, we gave out awards based on biometric screening, blood pressure control, and on mostly process-based measures, right? Statin prescribing, sometimes the EHR is consuming that drug, not the patient. But let's look at next decade. What I would request is that in 2018 to 2028, when we have a summit in 2028, that Dr. Shortell and Hector Rodriguez are telling us, hey, how are we doing cardiovascular disease outcome-based payments, and can Right Care Initiative be the backbone which helps us as provider organizations towards driving that change? So I made my own quadruple aim because everything has to be in that nice triangle. So here in the center is all this patient-reported outcomes, how we can lower burden of heart attack and stroke, and then we can lower healthcare expenditure, and then if there is saving, then we can have shared saving between Blue Shield and you. But we can all have that kind of saving. And I hope CDC also, I was excited to read about the Million Heart New Challenge. But there are outcomes. This is already work I'm stating from International Consortium for Health Outcomes. There's a consensus document there. You can all access it. But these are outcomes which we can track. There's enough data now. The data has been liberated for past 5 years now, so that we can look at that data to see what are the admission for MI, stroke, heart failure, procedure, look at mortality, and also what's important for the patients, right? We can look at Seattle and Dana questionnaire or Rose dyspnea scale and move away, just slowly transition away from just rewarding behavior for process-based measures like this A1C screening type of thing. And this is the whole picture, what matters to the patient most. These are all the different kind of outcomes we can track. But in the end, it distills down to what's important for patient, what's their quality of life. And this is, this was the marketing campaign for Be There in San Diego, which captures what's in it for the patient, what's in it for me who has suffered from heart attack or stroke. So I think, again, we all, I live in the value-based care world, we live in the payment model, but more and more organizations are participating in some kind of ACO model, some bundle payment model. Many of you here are actively leading those programs. And I think I do understand that capitation, global capitation is possible, but for some of us it's not reality right now. But we can always create some kind of ACO bundle share around cardiovascular disease prevention, tertiary prevention. I do understand there was a BPCI model around the episodic care around cardiovascular care that was looking at how does the care coordination happen, but there has never, I don't think there has been around primary or secondary or tertiary prevention of cardiovascular complications. And that shares, there's going to be no reform without payment reform. If you follow Richard Taylor, economist, or anything, payment reform is important. Shared saving, risk pool, those dollars will allow us to really have meaningful dollars to invest in structural change which we need to do under that system. So I think what I would, just from health, to health plans and to all my colleagues and economists and everyone in this room, can we start measuring and comparing cardiovascular disease progression like heart disease and stroke? And is it time to pay for shared saving based on those outcomes rather than process-based measures? And this is a very, this is our goal slide which we have been working for 10 years. This is like we're building the plane as we fly it, right? Type of thing. And you can see it's crowded slide. And I just think that it's possible that we could take out something from this language, this triangle, and instead of that, we add admissions for MI and stroke. If Hattie doesn't more like to remove things, then you still have some space on the top. You can add that, really concrete objectives, So I think, when I talk about value-based care population health, I sometimes sound in a university setting like I'm a climate science person talking about global warming. But I do think that, things are changing, and I was listening to Greta's speech and this quote really resonated with me. So I do think that we can make that change. The pace is picking up and the debate is shifting. And I think we're still building the plane as we fly, and someday we're going to have a right kit initiative, fully built training aircraft, better than Boeing 737 MAX in 10 years. But I'll end with a clip I want to show.
Some people like to climb mountains. I like to build planes in the air. I grew up wanting to be on a plane, wanting to be up this high. Sometimes the temperatures are on the altitude of 60 below. It's crisp, it's refreshing. You never know what you're going to come across up there. Maybe Allard? Owls. These people back here, that's why I come to work. That's why I build airplanes in the sky.
We're not just building a plane here. We're building a dream.
I love this job.
I got a lot of nights out here. When I look over there and I see that little kid, I look in his eyes, that's all the thanks I need.
Yeah. In a sense, this is all what we do, and I just want to end with, isn't it time? And thank you for all the support you have given to me and my team for all these years. Thank you.
Thank you. And now we're going to hear from Steve Chen. Yeah, the building is playing while we fly, but you really think it's a good thing to talk about.
Thank you. I just have to ask a question before I start. How many pharmacists are in the room? Raise your hand. So when it's a ratio like this, we use a handful of pharmacists and the rest not, I'm usually arguing about why pharmacists need to sit at the table. And it's really nice to be at a meeting where everyone before me has already said why pharmacists are very helpful. So I do appreciate all the work that all the leaders in this really do very much. So I will be brief. Hattie said 2 to 5 slides, that means 2 minutes, right? So I'll be as quick as I can. Because I think a lot of this appreciates required. Well, I will spend a minute on something here. If you're not engaged with pharmacists, your organization, you're leaving major quality and safety gaps on the table. That's not an exaggerated statement. There is data to prove this is true. So here's an infographic that the California Department of Public Health, Dr. Nix, and the News of our team allowed me to partner with them on. highlighting why medications matter. You can see just some of the highlights here. Look, half of patients stop taking prescription drugs on a regular basis. That almost doubles to 80% or so in all these conditions that are asymptomatic, like high cholesterol, hypertension, right, by year 2. This paper that came out last year from our team in San Diego, our UCSD partners, identified that $528.4 billion a year was left on the table due to optimized medication therapy, 3/4 of hospital admissions due to suboptimal use of medications. And that number 4 from the FDA, the 4th leading cause of death in the U.S. is attributed to medication-related problems. That's in the inpatient setting. No one has any idea what that number is when it comes to the outpatient side. Some of the estimates that I've seen are over 700,000 lives a year lost because of misuse of medications. Now we're arriving at cardiovascular disease, aren't we? So there's an epidemic of misuse of medications that really needs to be solved. And I'm excited that many of the people here in the room are using pharmacists for that purpose. The standard of care for what I'm talking about here is not just pharmacists on the team, it is pharmacists on the team, but it's comprehensive medication management. I'm not going to go through every single piece of it, so you know what we're talking about here. It starts with taking the right medication. That sounds pretty simple, right? You get an indication, you have a patient, it's pretty easy. It's not that easy, right? There are many drugs in different classes, many subgroups, many comorbidities, etc. So it starts with the right drug choice. It's the right dose. I can tell you we've done gap analyses for health systems and for health plans on use of medications, and quite often we find that people start the right medications, but they don't actually get to the right dose where it actually does something, right? So the right dose is critically important. We need to account for medication safety. That means, are there any drug-drug interactions, drug-disease interactions that can be harmful for that patient? Can they use these things that we give them? Right? Some of these things we give them are relatively complex, and for certain subpopulations, especially for the underserved that we work with, these are very challenging devices to use. So just hoping they're going to use it right, read the instructions is not going to work out, I guarantee you that. And then there's the affordability factor. Like, are there alternatives that they can get at no or little cost? These are all things that pharmacists trained to do, and I guarantee will be very helpful in their organization in accomplishing this. Now, skipping to the evidence part, if you look in your packet that Hattie so nicely put together for you, there is a summary of pharmacists on the character. I think most of you have seen this. Thank you, Hattie Hanley, for helping to sponsor the work of this paper. But this highlights just a handful of some of the best research projects that have highlighted the value of pharmacists on the care team. So I'm not going to go over that again. There's much bigger volumes of literature that summarize that. But there's the issue of sustainability, right? We started talking about that today. And that means, look, as Dr. Betsy Thompson highlighted at our CDC meeting about a month ago, there's no new money out there. So you have a great idea, you're going to pitch it, who's going to pay for it today, right? That's the issue. You need to pay for less of the low-value care, more of the high-value care, where that's a work in progress. So that's one thing we have to keep in mind. The second is, we already talked about it before, there needs to be a value-based payment model that works with pharmacy. Right? Pharmacy traditionally is not something that gets paid for clinical services. We are providers in California, but there's no mandate to pay pharmacy. So we're back to that issue of how do you pay in a way where health plans don't feel fleeced, feel like you're just paying for service and always works out. It has to be data-driven, it has to be quality improvement-driven. You have to get results. There has to be a value-based payment model that works. And for that matter, there has to be a quality improvement process that drives that as well. And then there's the issue of accessibility. We're talking a lot about pharmacists that are embedded into health systems and clinics, right? There are other places where this care can be delivered, but I can summarize all the different places where this happens. This happens in hospital-based clinics, it happens in medical homes, it happens by video telehealth, by some telephone services for the low-hanging fruit, but there's kind of an under-tapped resource. And I know Dr. Flynn mentioned this in his presentation, but the community pharmacist is in a major state of evolution right now. Right? In very little amount of time, there will be fewer pharmacists out there as you get more automation, get more consolidation, more collaboration between plans, PBMs, and pharmacies. But these pharmacists are very committed to doing what they trained before to do, which is document drug therapy for the patients they serve. I can tell you for the underserved side of things, we have remarkable networks of independent pharmacies that are USC graduates. I think half of the pharmacists in community pharmacies are still USC graduates in California. And they go back to the neighborhoods to give back, to help their neighborhoods. And they're just dying for these opportunities to partner with you all, health systems and plans to do that. So we're trying to foster that through something called the California Right Meds Collaborative. This is a collaborative, training collaborative that's dedicated to providing optimal medication therapy for high-risk patients in their communities by creating a curated network of community-based pharmacies that offer comprehensive medication management. What's really important is we completed a 3-year CMMI grant with Ultimate Health Services. With that data, we came up with what we thought was a fairly reasonable value-based payment model, and we're using that in this collaborative. And a couple of health plans, LA Care and Inland Empire Health Plan, has signed on to utilize that value-based payment model and get that started. I should also add that thanks to Blue Shield California, to HealthNet, we have some of their people involved in shaping this collaborative as well. So really excited about all these partnerships that came on our way here. The way it works, simple word picture, the health plans stratify patients from high to low risk. They identify these curated networks of pharmacies that we help them identify through a questionnaire, through an on-site assessment, whether they can really deliver this care. They then send the high-risk patients based on specific flags or algorithms to these pharmacies, and then we've been fortunate to have a number of schools of pharmacy that would serve as coaches and resources to advance CMM for these different locations. So I'm going to cut that very short. There's many other things we're involved with. We're involved in the whole person care program, the seamless level 15 waiver, all these other things that are coming up in CalAIMS. But the bottom line is I want to thank all of you in this room for helping us to change this narrative from being the most overtrained and utilized healthcare professional in the nation.
Thank you, Steve. And now we're going to hear from Christine Thorne, the Chief Medical Officer of either San Diego University Best Practices and UCSD.
Yes, I will try to keep it brief. I didn't bring any slides. I'm also not Tony tomorrow. My apologies. But I think that there's a couple of things that have come up both in my review of the right care data and in our discussion today that we really need to address. And one of those is the data and barriers to data. When I look at the San Diego data reporting, I realize that there's many low-performing groups, and those groups are not groups that are part of Right Care Initiative, and the groups that aren't a part of it down in San Diego are often not a part of it because they can't report data. They want to come, they want to do the improvements, but they are IPAs, they're coordinating 40 or more EHRs, paper, charts, and those sorts of things, and they can't do the reporting. The challenge that I hear in addition to that is that the health payers have trouble getting our data. We have trouble seeing their data. We all have trouble seeing health system data, either if you're not in a health system, or if your patient has an MI, and I actually work in a clinic that is UCSD, and I look at Scripps Mercy. Patients think that they're our hospital, and I say go to the ER, and I specify go to the one behind me, not the one in front of me, but they get turned around and they go across the street to the giant red emergency room sign, and then I don't necessarily know what happens with them. And so I think that, you know, what we can't measure, we can't fix, and we can't value. And I think that's one of the pieces that's been most telling for me when I look at kind of statistics and why we do them. If you look historically, economics never quantified any work in the home, and just because it doesn't earn money. But then it's hard to value that as a society. And so when people leave the home and that work is undone and has to be replaced, you get into some interesting economic things. When we don't know where we're at, we can't do PDSA cycles. When we don't know whether our patient picked up the medication and it was paid for or not, we don't know whether our prescription was of value. When we don't know if our patient had a heart attack and went across the street, we don't know if we did our jobs well. And so I think there's a lot of opportunities there. I'm really encouraged to see the amount of data we have, and I know in San Diego we have a lot of participating groups that give good data and work together. We have HIEs, we have many different things, but we still have a long ways to go to measure what we value and to talk about that. And even looking at this right care triangle here, the self-measured blood pressure monitoring is a key example. I don't know where that goes in my EHR. Friday I saw patients and I probably looked at 3 different home blood pressure monitoring logs that were all handwritten that I hadn't seen before. And then I turned around and handed them back to the patient. What was I going to do with them? data enter it myself. I mean, I have enough problems. All of that data was lost. Not to mention it wouldn't count for HEDIS anyway. So, I think there's a lot of work to be done there. And, but once we get the data, I think there's an additional challenge of knowing what you need to do, and having the data is not enough. If that were true, all of our diabetics would be well controlled, right? They all come to us, we say, here's your A1C, here's what you need to do, and they say, Doc, I got it, I don't need to go to diabetes education, I know what I need to do. But there are a lot of steps in between that we really need to focus on. And for Right Care and for our university best practices and our data groups, the things that I see that changes whether a group participates and gets benefit or not is, the entrance through the door is the data piece. But once we get past the data piece, it's, do you have physician leadership who's supported to be there? Either they have enough autonomy in their job to be like, this is important, and even though you're technically not paying me to go, this is going to benefit us, and so I'm going to show up. Or, do they have enough time separate from their clinical commitments to show up on a Monday afternoon and talk with us? Those are important things. And then, are they empowered when they go back? Do they go back and present and say, this is what I learned, and this is what we need to do, and we're going to change the system, and have that be listened to and valued and acted upon? Or do they go back and kind of talk into the wind and say, this is important? Everybody says, that's great, but we've got these other competing initiatives, other business issues that need to be addressed. Really who's in charge of what kind of happens next? I think bringing into alignment a lot of our interests from medical care side to the business side to the metrics side really leverages the change and has galvanized a lot of the benefits that you see since San Diego started way back in the day. But without further work on that and without continued attention to how we make those changes, how do we do what we know we need to do, and how do we bring all of the different systems that influence that into alignment to achieve those outcomes, we can't do what we want to do. We can't see the end benefit of reductions in heart attacks and strokes. There's been good work, but you've seen there's upticks. I think there's a lot of work still to do, and I know docs have started to feel, and their staff has started to feel like they're getting pecked to death with good ideas. But I do think that if we can bring these things into alignment, we can really continue to achieve our goals and set new ones and spread this idea beyond the leaders in this room to other groups who really could benefit from it and their patients.
Thank you so much, Christine. Very helpful comments. We are going to take time for just a couple of questions or comments from the audience. We really are trying to get us back on schedule, so there's not going to be a formal break. You all know, take your bio breaks as you need to, and we'll keep going. While you all think about your questions, it's partly spawned on by Christine's comments. I'm thinking about my days back. I was at a chief medical director for a health plan for 7 years back in the early 2000s, and rolled out a number of programs, one around diabetes, another and we were trying to improve management. And I have to say, I think if I were sitting where either one of you were and I was looking at these measures, yes, I'd be very helpful for 2019, but I was feeling depressed myself, maybe, about the movement today. And I'm wondering, one, I think, Scott, you kind of addressed how you're approaching that and why you're not feeling so depressed. But how do you push that to your leadership team and the executive, in the C-suite when, I know there's a mandate, you work with required to meet certain metrics, but are they still with it? We've talked a lot about the need for champions, but that's not just the clinical champion. You usually have to have your leadership on board too. And I just love to hear some fairly frank discussion about how difficult this might have been.
Yeah, sure. Actually, initially it was very entertaining, I guess is the right word. Being the only one of the health plans knew what gray care was. And so, and again, we got the mandate in October of 2015. So we got they passed me in December, I think, I don't know the plan. And we got together by May or so, 2015, or 2016. So when you get the plan together by May of 2016, and then you actually start working on it and fleshing it out and then trying to implement it, we did 2 groups in 2016, 7 groups in 2017, and we took it up to 23, I think, more in 2018. So I'm not surprised at that at all. So that's why I'm not wiping my tears right now. I think it's going to keep going. The part that frustrates me is I've engaged all my good partners that I already know. How do I reach the other 144 groups, right? And I got 32 involved. How do I get this alone? I don't know I can do that alone. I'm going to need some other help from other people, and perhaps some people in this room. So that's the part I'm very hopeful about, that we have some people that know this stuff, and it's not just me out there with the shield saying, hey, it's a pretty good thing we got to figure out how to do it. There's other people involved. So that's why I'm cautiously optimistic. Second thing is right? And it shows results. All right, so following what Brock says, all right, so I got something that is meaningful, shows results, and can save money. Figure out what do you want me to do to pay for it? Let's do shared savings. Let's do some kind of value-based pay. Because as Steve said, there's no more money, right? The public can't continue to pay increasing premiums. They're maxed out on this. It's coming up to 20% of the dollar. So how are we going to repurpose the money and spend it more wisely? And shared savings or a value-based payment or some kind of risk arrangement where the groups do get reward for the money that they're spending to try and improve that care. How do we do that better? I think that's the way of the future. I was really surprised that only 42% of the providers thought we're going to need some kind of value-based arrangement in the future. Man, they must have their head in the sand somewhere, because I don't see that being sustainable. I am primary source of income. That's got to change. Because that's when you have money at risk, when it's somebody else's money, you don't care. When it's your money, you care a lot. So that's why it's important to be better part of it.
Thanks. Jean, did you want to?
Yeah, I think it's good to have clinical leadership that it knows the business of medicine. And I think all of us leaders here have to talk the language depending on where they are. So we as docs can talk to a member as if we were a physician. We can go back to organizations and make sense to our CFOs and COs and CEOs. So I think undertaking was the first lever that we used to get something put together. So I have to say that was the impetus behind this. But as it did good work, I found more things to put in to make it so lucrative to the leadership team, keep investing more technology, get to do things smarter. So if their team, so the first year, we had a zero investment and we had $9.2 million savings. The only way we could do is to do things smarter from the existing teams, and we did that. So we added scripts and we did a more wholesome outreach with the coaches rather than just one person doing one HEDIS measure, another team doing another HEDIS measure. So it makes sense to make it lean, efficient, right, less waste, but also to do the right thing. So you have to make it sound good to the leadership teams for them to get hooked on to something.
And I'll just follow on one more thing about the Blue Shield leadership. My boss is here, Melinda Stoll, and we have another fellow R&D here, coach from our quality team. So it may have started off as a quote-unquote one-man show back in 2015 when I was at Tech, but it has rapidly grown. Our boss's boss's boss, who is now the EVP for healthcare quality and affordability, is a huge proponent of this and totally gets it. And it's been spread throughout the organization. So I don't see this going away when the mandate expires here. Matter of fact, we're being encouraged to keep going forward with this. So I don't see it going away.
Great. Questions, comments from the audience? We have time for at least one or two.
Dr. Jessica Nunez de Ibarra from the California Department of Public Health, a wonderful right care partner for many years.
I just want to thank everyone.
It's on it.